Hi everyone, my name is Emerald Terrell and my image analysis will be on the oblique ribs. The oblique rib projections are performed to best demonstrate the axillary ribs. Oblique ribs may be conducted either as an anterior oblique or posterior oblique view. In order to perform oblique ribs, you may either do AP or PA, whichever is facility protocol. The AP oblique view specifically focuses on the axillary ribs. The rib series is often considered to be an unnecessary, unjustified projection in many radiology departments. When imaging the AP oblique ribs, the axillary portion of the ribs closest to the IR are projected free of superimposition with the thoracic spine. The posterior ribs closest to the IR are also well shown. When imaging the PA oblique ribs, the structures shown are the axillary portion of the ribs farthest from the IR and projected free of bony superimposition with the thoracic spine. The anterior ribs farthest from the IR are also well shown. When you receive an order for an oblique rib exam, you must first set up your room. Your image receptor should be 14 by 17 inches and placed lengthwise in the bucky. You will then move the tube back to 72 inches in order to minimize magnification. After the room is set up, you will then go to receive your patient. It is important to ask for identifiers to ensure you have the correct patient. I like to use their name and birthday or name and last four of their social security number. As you prepare the patient for the exam, inform them that they cannot have any buttons on their shirts or in the pocket of their shirts, and women must remove their bras as to remove any artifacts from the image. Offer them a gown so they do not feel uncomfortable. In order to get an acceptable image, the patient must be able to perform the breathing instructions you give them and be able to hold as still as possible. For the AP oblique projection of the ribs, the patient must suspend breathing at the end of full inspiration for the ribs above the diaphragm and at the end of deep expiration for ribs below the diaphragm. When performing the PA oblique projections, the breathing instructions remain the same. The patient should suspend at the end of full expiration for ribs below the diaphragm and at the end of full inspiration for ribs above the diaphragm. For the AP oblique ribs, have the patient stand with their back to the wall bucky. Using the RPO or LPO position, position the body 45 degrees with the affected side closest to the IR. Center the affected side on a longitudinal plane drawn midway between the mid-sagittal plane and the lateral surface of the body. You will position this plane to the midline of the grid. You will then have the patient abduct the arm on the affected side. We do this to carry the scapula away from the rib cage so it will not be in the image. To make the patient more comfortable, rest the patient's hand on their head. You can then tell the patient to rest their other hand on their hip. You will then center the IR with the top 1.5 inches above the upper border of the relaxed shoulder to image the ribs above the diaphragm, or to a point halfway between the xiphoid process and the lower rib margin to image the ribs below the diaphragm. Your central ray for the AP ribs will be perpendicular to the center of the IR. The positioning for the PA oblique ribs is similar to how we do the AP ribs, except replace the affected side away from the IR, and the body will still be in a 45-degree oblique angle. In this slide, we will begin to do image analysis on an image of the AP oblique ribs. We will use the Merrill's textbook to help us understand the evaluation criteria needed in order to have a usable diagnostic image. For this image to pass, the following should clearly be seen. Is there proper collimation and a marker placed on the correct side of interest and not located inside the anatomy? For this image, yes. Is there approximately twice as much distance between the vertebral column and the lateral border of the ribs on the affected side as is present on the unaffected side? In this image, yes, we have that. Is the axillary portion of the ribs free of superimposition with the thoracic spine? Yes. Are the 1st through 10th ribs visible above the diaphragm for the upper ribs? Yes. If this was an image for the lower ribs, then we would want to see the 8th through 12th ribs. Are the ribs visible through the lungs Yes. And do we have bony trabecular detail and surrounding soft tissues? Yes. So this image would pass. For this image of a PA oblique rib image to pass, the following should clearly be seen. Proper collimating and a marker placed on the correct side of interest and not located inside the anatomy. Now we are missing a marker, but we do have correct collimation. Do we have approximately twice as much distance between the vertebral column and the lateral border of the ribs on the affected side as is present on the unaffected side? Yes. Is the axillary portion of the ribs free of superimposition with the thoracic spine? Yes. Are the 1st through 10th ribs visible above the diaphragm for the upper ribs? Yes. Are the ribs visible through the lungs? Yes. And do we have bony trabecular detail and surrounding soft tissues? Yes. So all in all, this image would pass even though we are missing a marker. Now that we have seen what a good image of an AP and PA oblique ribs looks like, it is time to see if we can point out if there are some mistakes in the next image. We will still use the same evaluation criteria. This is an image of a PA oblique ribs in the LAO position. We can automatically see that we have clipped the anatomy and there is not twice as much between the vertebral column and the lateral border of the ribs on the affected side as there is on the unaffected side. We are also missing a marker. There needs to be more rotation because it does not look like the patient is rotated 45 degrees. The axillary portion of the ribs is also not able to clearly be seen because it was clipped. This image definitely calls for a repeat in order to be deemed a usable diagnostic image. This is why it is important to keep a pocket marrows on hand during work so that you can understand whether or not your image is going to be accepted or rejected. Some things to remember. The opposites of these projections are the same in AP or PA. It is very important that you listen to your text during clinic so that whenever you begin working, you know all the little tips and tricks to help make you a great tech.